great welcome. It's so lovely here. I came to Madurai and Coimbatore in 2003 when I was a resident, and everyone always said, you've got to go to Pondicherry, and I thought, okay, maybe someday, and this is the day. I've wanted to come here for so long. Thank you for this welcome. I also am older than almost everyone in the room. But I do remember being a resident, and I remember after a long clinic day how you had to go back and sit for the visiting lectures talk. That was awful. I'm so sorry that you all had to come back instead of coming. So I'll try to make dry as not dry as I can to make it worth your while. But first, I sort of would like to know my audience a little better. So if you're a resident, can you just raise your hand? And a fellow? A cornea fellow? 3? Wow. And then another subspecialist attending? Glaucoma's in the house? Retina's not here, right? Retina came. No, Retina wouldn't come to a dry eye talk. Okay, let's see all the ways we can you hear me all right? Is this fine? Okay. I consult for a company called Dompe just this year, and they make a new drop that's the growth factor drop for neurotrophic keratopathy. Do you have that yet here? Maybe not? Yeah? But I won't be discussing it at all. I often joke for dry eyes that to make it interesting, I want to give everyone in the audience a dry martini and have dry ice blow me to the stage, and then I'll give you dry fruit, and then everyone would say, oh, the dry eye talk, this is amazing. But I have to say, this is the most enthusiastic introduction I've ever had for a dry eye talk, so you're already ahead of it. The truth is this, is when you're a cornea specialist and someone asks you to give a dry eye talk, I always sort of think, ugh, it's so hard to give a dry eye talk for me, and I'll tell you why. And I think it's because dry means something different to everyone. When a patient comes to me and says, I have a dry eye, often I, as a cornea specialist, am thinking, your eye isn't dry at all. And we get a lot of referrals. Dr. Swati and I are talking about glaucoma referrals, and glaucoma often says, please refer for dry eyes. And from cornea, we think, I don't know if that's dry. I'm really interested, and so we'll have time at the end of this talk to have some interaction. I'm very interested if what I present to you as a United States dry eye is what you experience as an India dry eye. So let's make sure we talk about that. And then I want to just go a little bit in depth to an important concept about what market-driven dry eye versus evidence-based dry eye. So what all the advertisers are telling you to use and what evidence should tell you to use. Do you have a big marketing push here in India for certain medications still? Okay, so we'll just talk about this. There are two real disclaimers I want to point out, is that I'm from the United States, and not only from the United States, but from the University of California, San Francisco Proctor Foundation. We are the nerds of ophthalmology in the United States. So this is a proctor approach of how to approach dry eye. So if somebody comes from New York City, it will be a fancier talk and a little bit of a different approach. So this is a proctor approach. And then when I give a dry eye lecture, I always just want to say, if you have a patient with dry eyes who gets better with artificial tears and warm compresses, that's great. I just never see those patients. Nobody ever refers to a cornea specialist because a patient's doing well on artificial tears and dry eye and warm compresses. So if that's what you're doing and it's working, you can probably leave because that's great. So let's talk about dry eyes. So this, in an academic lecture, is where I lose the audience completely, because this is what we should, as cornea specialists, all agree on as the formal dry eye definition. There's a dry eye working group, a group of really smart people who create this 43-word definition and a huge flow chart And I promise you, you just had snacks. And as soon as I go through this, you will all be asleep, except for my professor, Dr. Witcher, who will stay awake to support me. So I'm not going to go through this. I'm not going to go through the official dry eye definition because I believe in my heart that you can all read it and figure it out yourself. What I'd like to do is just come to an agreement on what I'm going to discuss as dry eye. That there exists in the population a group of people who don't make aqueous, and they're the aqueous deficient dry eye. So we would call that keratoconjunctivitis sicca, kind of a Sjogren's population. There also exists an evaporative loss dry eye. The tears are escaping, evaporating. There isn't the lipid layer supporting the tear film. There is an enormous overlap between aqueous deficient and evaporative loss. On top of this, we have to agree to a few things. There is a group of patients who say their eyes are dry, they feel awful, and their eyes look perfect at the microscope. So we call that pain without stain. And this is a different lecture, and this is this neuropathic pain group. The opposite is true. There's a group of patients who are referred, I don't know, someone said my eyes look dry, and their eyes look awful. They have a tremendous amount of corneal staining, no pain, and this is, of course, neurotrophic keratopathy. I just want, since we have the residents, trainees here, the way to diagnose neurotrophic keratopathy is you have to prove that the patient doesn't have corneal sensation. So this is a trick when you're wondering and theorizing all the time, you've got to check corneal sensation. This is a pearl to being a great corneal specialist. The cornea can only heal itself if it has proper innervation. The only way to test that is before anesthetic, you've got to be checking yourself for corneal nerve function. On top of this population of aqueous loss and evaporative loss is this huge population that has a lot of external disease stuff. And they believe their eyes feel dry. And this is the population that people call dry eye. It's a complex group of people. In the United States, a very typical referral we get is this. I have a patient who's tried artificial tears, warm compresses, lid scrubs, cyclosporin, lifitegrast, which I now know you don't have that. I'll explain that in a moment. Nothing's working. Please evaluate. The patient is frustrated. So this is very typical. Something's wrong. A lot of doctors have seen them. The patient's angry, and I know this is a lot of chair time for me. And I often say that residents will say, I love cornea. I love the ulcers, I love the surgery, but I can't do it because I cannot stand the dry eye evaluation. It can be a painful dry eye evaluation, but let me tell you why the dry eye evaluation makes you a better doctor. The reason why is because if it's done well, you can play two roles that are fabulous roles to play. One is the detective, and two is the old school true doctor with a leather bag who listens and cares for the patient in front of them. If you do a dry eye evaluation well, more than any other examination, if you just listen to your patient, they will tell you the diagnosis. It's kind of true for almost every diagnosis in medicine, but very true for dry eye. Let's talk about how we're a better detective. So another pearl for all the trainees, if something doesn't make sense, if the patient isn't responding to the therapy that you've initiated, when you're getting a referral for something new, when you are a cornea specialist, and I'm going to give you the secret to being a good cornea specialist, please tell me if you agree, you look at the cornea last. You have to look at everything else, and then you look at the cornea. So when a dry eye patient comes in, my room lights are up, I'm nowhere near the slit lamp. I'm all the way over. Dr. Seitzman, it's really nice to meet you. How can I help? And so they start talking, and I'm watching. And I'm just watching. I'm sort of listening, but everyone has a very similar story of the pain and the discomfort, and that this doctor didn't know what they're doing, and this doctor, and then I went to a more expensive doctor. I got more drops, lots of drops. Nobody's listening. It's a very similar story a lot of times, and I'm just watching. And I think, oh, isn't that interesting? They brought a water bottle with them. So I already know in my mind that I'm going to be working this patient up for a true Sjogren's syndrome just because they're carrying a water bottle with them. I notice, oh, that's interesting. She looks a little arthritic. Maybe I will evaluate her more for an autoimmune sicca evaluation. I'm looking at their arms. Patches of eczema. They're rubbing their eyes while they talk. I'm looking around their eyes. They have some periorbital hyperpigmentation. I haven't examined her, but I already know that the key to this person's examination is going to be underneath their lids. We're going to do an allergy and an allergic dermatitis focused evaluation. We have a ton of rosacea in the United States, and I don't think you have a ton of it here, but you do have it here because I saw it in Madurai just 2 days ago. So a mid-facial erythema, I'm noticing this is probably more of a rosacea evaluation. I'm noticing that they've had, well, that's some interesting plastic surgery. I'll make sure I evaluate their blink. I'll look for exposure. I'm counting their blink rate while they're talking. I'm wondering, do they have a neurologic condition? Are they on some sort of sedative condition where their blink rate is markedly decreased? I will be checking their corneal sensation. I'm noticing they look a little exophthalmic superior scleral show. I haven't even gotten to the slit lamp. I already know I'm ordering thyroid serologies on them. Is it a larger person? Could they have floppy eyelid? Are they talking about a cancer history? Then I'm certainly going to evaluate for a graft versus host disease. Some radiation-induced side effects, certainly common. And then lastly, there's a certain group of patients that talk about their eyes and their fingers are in their eyes all of the time. And so that's very common in a dry eye evaluation, that there's we call that a mucus fishing component or a self-induced trauma. So looking for mid-face rosacea, always remembering that women watch a lot of YouTube videos on how to cover up their mid-facial rosacea, so sometimes it's hard to figure it out. There's periorbital pigmentation, all these extra lines. One eponym is Denny Morgan lines, all the extra wrinkles underneath the eyelid. Little children who rub the latter third of their eyebrow away. That is a Queen Anne sign if you rub a lot. The larger person, floppy eyelid, exophthalmos, eyelids that don't close all the way. And now we listen. So I mentioned this at the conference before. This is not necessarily a proctor evaluation, but my last name is Seitzman. This is a Seitzman question. Every dry eye evaluation I do, I always ask this question first. And it is, when is the last time your eyes felt normal? And what I find is you have two buckets. The bucket of, it was June 2017 when something happened, or the group where they can't figure out they can't remember. And the group where something happened, it's rarely a true dry eye. For example, they say, I moved to California and it bothered me. Someone changed my contact lenses. I changed my apartment. It's often something else like an allergy-focused evaluation. We have a reasonable population that is fine until cataract surgery, and that all of a sudden their eyes feel uncomfortable. And that's either a neuropathic condition, but we find, again, in our large ocular rosacea population, that we have exacerbations of ocular rosacea, burning, stinging after cataract surgery. Also common is recurrent erosion after laser surgery. So I got laser surgery, or my child poked me in the eye. Recurrent erosion is a nice, frequent masquerader of dry eyes. And we'll talk a little bit more about recurrent erosion later. This is very common, and one that I really want to caution you to think about. I was fine until I got conjunctivitis. So I was fine until something happened, and that something was real, but it entered them into the medical system, and someone gave them drops that didn't work. And so somebody else gave them more drops, and then somebody else gave them more drops, and somebody else gave them more drops. And then they finally come to me, and the answer is, well, you need no drops. And this idea of preservative benzalkonium toxicity is huge, and people who do not respond to conventional treatment when they have are commonly toxic to their regimen. Glaucoma evaluation in particular, it's super common for them to just be experiencing drop toxicity. I'm worse in the morning. What do you think about if somebody says, my eyes feel stuck in the morning and they're worse in the morning? Recurrent corneal erosions, for sure, that's what I think too. And then the population, I cannot remember when my eyes felt normal, and we do the whole evaluation. So what is our dry eye evaluation? So remember, I haven't even come to the slit lamp yet, and I already have an idea of what will happen to the patient. Of course, we use Schirmer testing. Do you use Schirmer with or without anesthesia here? Or does it depend what? Oh, because you're also smart. Yes, Schirmer without is what we do as well. We don't care what the number is. What we care is if it's 0 or 30. So a lot of patients understand the Schirmer testing, and some doctors and many tests we'll talk about say it's the Schirmer test increased from 5 until 7. That's clinically insignificant to us. We put a Schirmer strip in to know, can they make aqueous, yes or no, or do they make a ton of it? And when they overflow, we know it's not a true dry eye. We also use lissamine green. Dr. Jack Witcher, who's in the audience, is my professor at Proctor, and he formalized the use of lissamine green for a Sjogren's evaluation. And so the American College of Rheumatology uses Dr. Witcher's scale of how much lissamine green is on the ocular surface to help a person qualify by the ACR, the American College of Rheumatology requirements for a Sjogren's disease. You get points if you're SSA positive, points if your ocular surface stain scale is positive, and Dr. Witcher created that scale with lissamine green. So of course we use lissamine green to get an idea if there's desiccation in an interpalpebral location. We always use a look under the lids to maybe there's an SLK, superior limbic keratitis. We put in fluorescein, of course. We look for a tear breakup time like everybody else. It's interesting looking at people's tears. Is there a lot of makeup, a lot of debris? Is there mucus? Get an idea of the quality of the tear film, how quickly it's evaporating. And of course, the dry eye patterns that we all teach you. If it's interpalpebral, it's dry. If it's diffuse, it's toxic. If it's inferior, it is most likely exposure. So of course, we look at all of this, come together with a full picture, and then all the other external disease stuff. You can spend forever looking at people's lids. There's a big culprit here. There is, lid margin telangiectasia and meibomian gland dysfunction all the way off to your left here. This we would call ocular rosacea, sort of a posterior blepharitis. And this we'd call an anterior blepharitis. And then I'm in this funny stage of my career that everybody has Demodex, and I'm constantly pulling, epilating, and let's see if I can come up here. Yeah, I can't stop myself. I just epilate people's lids, and then I make the fellow go to the microscope with me, and then they just wave, and I wave at them, and I think, oh, maybe that's pathologic. A lot of people, because we have a big ocular rosacea population, and Demodex is more common in rosacea, we see it a lot. I think we'd all agree that, oh my goodness gracious, I think we'd all agree that this is called blepharitis. And what's very common in the United States, curious if it is in India, that the assessment is blepharitis, warm compresses, and lid scrubs. I think, is that common sort of here? Or very common, right? So this is a very Proctor thing, I'm going to say. And it's funny, people get very emotional about their warm compresses, that you have to tell them either to do it or do it a certain way and how long, and with lid margin massaging. And then people are very particular about their lid scrubs. It has to be baby shampoo or expensive solutions. This is how we believe at Proctor. And I really believe this. If you're ever to tell a patient to put their fingers near their eyelashes for any reason, you have to have an excellent reason to tell them to do that. People, including us smart people in the room, people are filthy. No matter who you are, where you live, their fingers are filthy. And we know that. We can study people coming in and out of bathrooms in any country. Nobody washes their hands. We culture everyone all the time at the Proctor Foundation. We culture every E. coli, group B strep. We know, we can tell people don't wash their hands and they rub their lids. We really don't recommend lid scrubs for posterior blepharitis, for meibomian gland dysfunction, and everyone else seems to. And the question is why are you telling people to rub their lashes when they have meibomian gland clogging? What are you hoping to achieve? And what we find is that it just makes it worse. You can see the blood vessels, and they really exacerbate their own situation. So if they have a ton of scurf, and there is a staph overgrowth component on their lashes, I think this person should probably do some lash scrubbing. But look at these perfect lashes. What are you hoping for them to accomplish? And then when I have this conversation with the lash scrub people, they say, well, we need to unroof the meibomian glands to get them to express. That's usually what people say. No one ever tells a patient to take their fingernail on their margin and unroof. That would be a terrible idea. So if there is meibomian gland clogging, we believe in warm compresses. If there is anterior blepharitis, we believe in lid scrubs. But we don't always believe they have to go together. And I know that sounds funny and sort of controversial in your external disease, but the principle is true. Just treat what you see and don't cause a problem by your recommendation. And then all of the other external disease stuff. The secrets of the world might be underneath the eyelid. Never forget to flip the eyelid, especially as a cornea specialist. You learn a ton. United States residents have a hard time differentiating follicles from papillae. Is that an Indian problem or no? Tell the truth, because I don't know if I should continue. You have no problem, right? Say again? Oh, that's so funny you say that. The front of the room, so you know, residents, the front of the room says there's a problem, and all of you are shaking that there's no problem. Well, I'm sure you know, but a cheat of papillae is evaluating under fluorescein, because fluorescein stains between the papillae, and it is a good way to teach yourself to see the vascular tufts. One of the ways when you become an attending, everyone thinks you're smart, is because you look underneath the eyelid at the superior cornea. In general, residents and fellows forget to look at the superior cornea, so fellows out there, don't forget. It's funny how EBMD hides under the superior third. I said this at Cornea Connect, but I believe it to be true. There's no other field in the world where you're allowed to specialize in the bottom 2/3 of it, right? You can't be a kidney doctor. I only look at the bottom 2/3 of the kidney. And it's funny that as a cornea physician, so many people just forget to lift up the lid. There's a lot of surprises underneath the superior limbus. There's SLK, there's EBMD. This, we're going to talk about this picture for a little bit. This looks like a normal slit beam picture. But if you look really carefully here, you can see tiny little microcysts. Can you see that all the way in the back? Do you know, I'm curious, because I only know this from the United States population. In an Indian population in a textbook, what percentage of the population is supposed to have anterior basement membrane dystrophy? In the United States, it runs about 10%. Very low here. Say that. Say that again. There's no exact description. You see very rarely. So in a United States population, the number cited is usually 10%. And then when I say to my residents and fellows, that means you need to be seeing this on 1 out of every 10 patients. Do you? And they say no. And I say, then you're not looking carefully enough. Now here, it may be that you just don't see it. But let me show you some tricks on how to look for it, because the truth is that most people miss it. So you can see the huge swirls in the geographic EBMD, like this picture, right? No one's going to miss this. You might miss it if you don't lift the lid, but you have these kind of geographic map dot fingerprints. So you have these maps and dots. You're not going to miss it when it looks like a textbook picture. It doesn't look like a textbook picture most of the time. There's a cystic component, just the dots of map dot fingerprint, that a lot of people miss. And you cannot see it in direct illumination. You only see it in indirect illumination. And the patient says it in their evaluation. They say, oh, in the morning my eyes feel stuck and I have a foreign body sensation in the morning, and everyone else says their corneas are normal. But you all won't. Because what happens is you move the slit beam off, scan the cornea, and you don't look at the slit beam. You don't look at the direct illumination. Oh, you're all going to be cornea fellows when you're done with this. The other secret pearl of a great cornea evaluation is you don't look at the cornea in direct illumination. You look at indirect illumination. That gives you all the secrets. Is this infiltrate still active? Indirect is the key. So let me give you I hope this shows. I put this in, let's see. This I just did before we left the United States, and I just put my phone up to the slit lamp. So I want to see if you can see something here. So this is just a patient, and oh dear, that's not going to work. Hold on. Rotated 90 degrees. So if you were asleep with your left ear down and examining a patient, this is what we're going to have to do. In the United States, we like to examine with our head toward the left. That's not true. I don't know why it's rotated like this, but just imagine that this is bottom. This is your split beach, right? And I want you to keep your eyes here. It's not a great video, but it's illustrated. Keep your eyes in this zone, okay? Oh, do you see them? Can you? Oh, I made you go. Did you see what I was talking about? And that it's teeny tiny little dots that you would probably miss in a quick evaluation, right? Because you're not looking for them. But if you look right here in that zone, they'll come back. I didn't see it there. That's great. But did you see them? Can you see that? Oh. Oh, there you go. Yeah, right there. Right? And you look in the rectal lumination, there are little cysts. And that, all of a sudden, this patient who's been treated for dry eye all the time, that's not their problem. You have to change how you're going to approach this patient. Okay, how do we treat dry eye? It's a complicated answer because this population is complicated. So there isn't really a correct answer for the whole population of dry eye, because what I'm trying to express our opinion is that dry eye is this big umbrella diagnosis. Okay, this is where we break and we all drink wine together. That's what we do in the United States. No, I'm just kidding. That's not at all. That's not at all what happens. This is a study that I want to talk to you about. I want to take a step back and I want to be really detail oriented about how we not ask the question, how do we treat dry eye? How do we assess if our treatment is effective? Okay, that's a different question. The reason I have a dry eye bottle here is to illustrate a point. The way in medicine, in an ideal situation, we decide if a treatment is effective is because we've interpreted a large, randomized, observer mass controlled trial, right? We take a population, we do a placebo, we do a treatment, we come up with an objective outcome. If it seems to be working in one group, we analyze the results. Where I live in San Francisco, there are a lot of grapes, a lot of wineries, and people drink a lot of wine in San Francisco. And people are very snobby about their wine in San Francisco. And people are always talking about, is it a good wine? Is it, I'll be honest, I can't tell you the difference. I cannot. But people publish all of these reports, this wine is great, this is, and then people are kind of known for their wine opinions. This was a study done about professional wine graders. If you give a bunch of graders the exact same white wine, but tell them that it costs something different. Oh, this bottle only costs $6, this bottle costs $16, and this one costs $53. The professional wine graders will always say the most expensive bottle tastes the best. This particular study was fun because they put a little bit of acid in the most expensive wine. Just a touch, nobody died. And they did it again, and they still say the most expensive bottle tastes the best. How can that be? The reason is because experimental findings are biased by our expectations. And this is a crazy thought that we really have to think about. From the time we've all been little, we've worked hard, we got good grades, we went to medical school, it's hard to get into ophthalmology, we keep trying. We think we're pretty smart. We all in this room want to help our patients. So when we give them this medicine and they come back and say, oh, I feel good. Obviously we think, I am the best doctor that ever existed. I have given you the treatment that has solved your problem. Because our expectations are that the patient will feel better, the patient feels better, and what we've done is come to the false conclusion that the drop we gave made them better. Now, I know you know this is sort of true because you do cataract surgery and you say you must take this drop 4 times a day and this drop 4 times a day, and there's a group that does it, and there's a group that you know didn't take any of the drops, right? And they come back and they're fine. But if they took the drops, you think it's because they took the drops, and if they didn't, you think that's funny that they did so well. Do you see where I'm going? So we're going to talk about in dry eye, how we can assess efficacy. The goal, as we said, is a large randomized observer mass control trial. The trouble with these is they're very expensive. In order to show small differences, we need large N's. The population has to be huge. This means you need a lot of money. Not academic centers don't have a lot of money. So the people who sponsor the drug trials are the industry themselves. And so we'd like to believe that we're getting honest results, but it's possible that the industry who wants to sell you the drop may not present the data in the most objective form. I'm not paid or not paid by dry eye companies. I'm just saying it's possible that the data shown perhaps are not as objective as we want them to be. So let me walk you through a graph of this is a huge dry eye study in the United States. As a matter of fact, this is one of the graphs that got this drug FDA approved, okay? So we're gonna talk about it. On the x-axis is the number of study days that the patient has been on it. It's a BID twice a day drop. This particular y-axis is a subjective scale called the VAS, which is the visual, say again? Oh, it's written right there. You're all so clever. Visual analog scale. And it is a 100-point scale that is like how much are your eyes burning, how much are they itching, how much are they... So in the United States, in order to get a drop approved, you have to show a statistically significant difference in a subjective complaint and an objective finding. You cannot move forward unless you show statistical significance in both. Okay, so this is the subjective component. There are lots of standardized forms. Their OSDI is a real common one. It's another 100-point scale. Just in general, how much do your eyes bother you on a scale of 0 to 100? And having looked at lots of dry eye studies, in general, people enter the study around a 40. My eyes bother me around a 40. That's a very average number. Of course, there's a large range. So here we have a drop. It's given twice a day over to 84 days. You start, and this is how much has your score changed. This means by 84 days, it's gone down about 30 points. A twice a day medicine, and you go down about 30 points. And in any study, a 30-point decrease of 100% scale is pretty good finding, I have to say. We wish it was a bigger, but that's pretty good considering most people are coming in at 40, 45, right? Okay. What drop is this? Do you have a drop that works this well in India? Maybe you don't have it. Of course you have it. This is an artificial tear. It's the placebo. Okay, so this is the drug that was studied. Okay, so this is a drug called lifitegrast. Do you have brand name Restasis here? Restasis is, you have that, right? 0.05 cyclosporin. So Restasis was the first brand name drop in the United States, followed 2 years ago by a brand name called Xiidra, X-I-I-D-R-A. You don't have that here yet, is that right? Okay, they're not going to be happy that you're learning it from me. So Xiidra is lifitegrast, and it is a complicated mechanism that's actually not well defined. And their marketers say lifitegrast may decrease inflammation, which is, it may, possibly. They say the mechanism is in a cytokine profile where I think ICAM1 has to bind to LFA, and when that binding happens, an entire inflammatory cascade continues, and lifitegrast mechanism of action is it blocks that binding, okay? So this is the drop that we have. Now let's look together, because we all know, we all don't have time. We look at the abstract, we look at the graph. It has the stars. We know to look for the stars. And it looks like this is going down more. And then the title of the thing is the drop works better. So what are they telling us? What they're telling us is when you use this new dry eye medicine, on average at 84 days, and in this particular study, they don't give you the number. They just give you this graph. So we have to guess together. So here's the placebo. What do you think? 30. Here's the lifitegrast at, 35, 37 sort of, right? Okay, so what they're showing us is after 84 days, this drop is very expensive. What you have is a 7-point difference on a 100-point scale. No one will doubt that that's not statistically significant. It is. I'm not saying, I'm not telling you what to do. I'm just questioning, is that clinically significant? It's an interesting question, right? Subjective data are very difficult to show an improvement. So if you look at lower back pain studies, and they're really interesting, they do meta-analysis for low back pain, and they evaluate surgery, they evaluate pain medicine, they evaluate yoga, they evaluate physical therapy. Everyone gets better after 6 weeks, right? So with pain, people tend to get, it's very difficult to show what affects pain. Migraine literature is very difficult. Depression literature is very difficult because it's a subjective response. So the subjective complaint is very difficult to sort out. The other concept I really want to just remind you of, to enter into a dry eye study, you have to score high on this visual analog scale, or the OSDI. You have to score high on this my eyes feel so dry test, right? So there's a phenomenon in statistics. If I were to have everybody in here stretch their legs and say, come with me outside, I'm going to time you. We're all going to run a 1/4 kilometer together. I'm going to time everyone, okay? And then I'm going to take the 5 of you who were the slowest, okay? And I'm going to take your average time. And then, only the 5 of you, I'm going to time you again tomorrow. Do you think that on average the slow people are going to get a little faster, or are they going to get a little slower? They get a little faster because they regress to the mean, right? So if you take people and enroll them at a high level of symptoms and you give them nothing or something expensive, statistics would dictate regression to the mean. So the question isn't a statistically, you have to really sort out if what you're seeing is just a statistical phenomenon or a clinically significant response. For subjective finding, that's hard. So let's go to objective findings. So we're not listening to the patient anymore. We're putting fluorescein in and we are staining their cornea, an objective finding. Oftentimes in dry eye studies, we use the Oxford Cornea Staining Scale. It's a 6-point scale, 0, 1, 2, 3, 4, 5. 0 means there's no staining. 5 means there's a ton of corneal staining. You can figure out in between. This is a different drop entirely that I know for a fact you have in India. This is a twice-a-day drop, and you look to see after 1 month what the change in their Oxford cornea staining is, and it goes down by a 1/2 point, okay? And interestingly, it kind of sticks at a 1/2 point the whole 6-month treatment of the study. Maybe here a little bit more? Yeah, I think we could all agree it goes to, but now with dry eyes, why do we want to treat them? We're afraid that this punctate epithelial erosion will lead to a secondary infection. As a cornea specialist, a 1/2 point difference in corneal staining, it's hard to get excited about. It's hard for me. If you've gone from a 4 to a 3.5, I'm still worried about your surface, frankly. But it's something, it changes in the positive direction. You've started the study, you've gotten better by a 1/2 point on the cornea staining scale. It's something, okay? What drop is this? You have it. Say something. Yeah. It's placebo again, right? So this is the placebo for the Restasis study. So this is this is the graph that made Restasis FDA approved. This is a really interesting graph. So since do I have time? I don't know. How am I doing? Oh yeah, we're fine. Oh my goodness gracious, you poor residents. I could talk until 7, but I won't. Let's just think about this. In the 70s, people sorted out that topical cyclosporin could help dogs with dry eyes become less dry. That's how cyclosporin came into the dry eye literature. Did you know that with dry-eyed dogs? And it's 1% or 2%. And so we know that at 1% or 2%, cyclosporin does have seemingly a steroid-sparing effect. It's an immune suppressant. Cyclosporin is an enormous molecule, and it is really difficult to put it in solution. Restasis is in an oil. if you ever give someone 1% or 2%, it's in an oily drop. It has to be emulsified because it cannot be solubilized, okay? And then in the mid-2000s, the technology for microemulsion came out, tiny little oil droplets. And the company that makes Restasis decided to test 0.05% with 0.1%. Now remember, what was used before is 1% and 2%. So this is arguably a teeny tiny percent of cyclosporin. So we measured patients, really great numbers, a big study on 0.05% and 0.1%, and we followed them, and placebo. So sort of everyone gets a little better, but what we have, interestingly, there's no stars at 1 month, no stars at 3 months. We're starting to get stars. Nobody actually realizes we lose a star here. But remember, when we talk about Restasis, we always say it takes lots of months to work. And this is why. This is this graph. It takes a long time before the stars come out. And what we're saying is that at month 4, maybe at month 6 for the 0.05%, there's a statistically significant difference between this line and this line, between a 0.05 change and a 0.07 change. So the question, I have no doubt that this is statistically significant, the question to just ask out loud, is this a clinically significant result to see a 0.2 change in a corneal staining scale on a 6-point scale? I'm just asking you to think about it because people get very emotional about Restasis. Everybody thinks it's a great drug, and it may be, but I'm just asking out loud, does this graph prove it to be? Do you see the difference here? This is last year. A beautiful study came out in the New England Journal of Medicine that checked oral omega-3 fatty acids for the treatment of dry eye. Do you know that study? It's called the DREAM study. Dr. Penny Asbell led it. She's a hoot. She's a super smart lady and a great analyst. What it showed, I won't make you guess, is that everyone got better. This is the OSDI, another 100-point subjective scale. Everybody came in around 40-something, and they left around 30-something. Everyone got better, and there was no statistically significant change in the patients who took omega-3 fatty acid for dry eyes. There are a couple things I want to say about this study. Is the week it came out, I had a patient return to me in clinic and said, "Oh, Dr. Seitzman, I am so much better." And I was like, "Great. Can you remind me, what did we do?" And she said, "You told me to take omega-3 fatty acids." And I literally had just read the DREAM report. And I was like, "Oh, that's great. Okay, do you want to keep taking them?" She said, yeah, I do. They're really helping me. I was like, "That's great." So in that example, who's right? Did she get better? Yes, of course she got better. According to this paper, did it have anything to do with the omega-3 fatty acid? Probably not. Interestingly, last year, the New England Journal did 2 other omega-3 studies. One, testing cardiovascular mortality, that there's no decrease in patients who take high-dose omega-3 fatty acids. There's no appreciable decrease in cardiovascular mortality. And then they looked again with stroke mortality, and there was no clinically significant difference. And I think they did it again with an oncology study. We don't have good evidence from the rest of medicine literature that omega-3 fatty acids really does anything. And so here comes the DREAM study that says, oh, also, it doesn't really have anything to do with dry eye. And everyone in ophthalmology went crazy. They're so addicted to the omega-3 fatty acids. They said the control was wrong. The control was a teaspoon of olive oil. It was a great control. We all have a teaspoon of olive oil in our bodies. I think you're getting where I'm going, right? We have to be very careful to determine if the drops that we're telling our patients to take are causing the effect that we want. In the United States, this is a problem because these drops are expensive. In the United States, this came out last year, ophthalmologists, they say eye care providers, so for us that's ophthalmology and optometry, prescribe more brand name drugs than any other subspecialties in the United States. Number 1 is glaucoma medicine. They prescribe brand name glaucoma medicines, and number 2 was Restasis. So in the United States, we're spending hundreds of millions of dollars on these drops. And I'm just throwing out the idea that if we spend so much money on drugs that have questionable efficacy, I'm not saying they don't work, I'm just saying they have questionable objective efficacy, then the companies that make these medicines have no incentive to make something that actually does work. Let's just say, as far as treatment is concerned, the reason we want Restasis to work, the reason we want Lifitegrast to work, is because they're non-steroid drops. That we all agree that there is an inflammation component to dry eye. Dry eye causes inflammation and is a consequence of inflammation. And when we put a steroid on a surface of a patient with dry eye, they almost always feel better. So with any other chronic inflammatory disease, we quiet with steroids and then we maintain with an immune modulatory therapy. And with dry eye, we should do the same. We should quiet with a steroid and maintain with an immune modulatory therapy. The trouble is with the ones that are available, cyclosporin, Lifitegrast, they're large molecules, and we have a very hard time obtaining therapeutic concentrations of these compounds on the surface of the eye. It's technically challenging, but we shouldn't stop from trying. We should analyze the results carefully, repeatedly, independently, objectively. You have to do your work of look, what is the y-axis here? How much did they spread it out? How much is someone trying to show me that the picture looks significant? How do we treat? Well, if someone has an aqueous dry eye problem, it's a plumbing problem. You have two choices. You either give them more water or you stop the water from leaving their system. So what's really proven to be effective is you give them artificial tears or you stop the tears from leaving. So punctal cautery, punctal plugs. In the United States, it's always an issue. What brand do we use? It doesn't matter what brand you use, except for not the get the red out brand. The kind that have the vascular constriction tend to be more toxic. So any brand preservative free, any brand tear is fine. If you use it more than 4 times a day, you have to use preservative free. We occlude punctum a lot, we cauterize a lot, we use a mild steroid a lot, and I understand the risk of steroid-induced glaucoma is higher in this country, but you could still use low-potency steroids very safely. Remember that with aqueous deficiency, you have an overgrowth of normal flora, so you're more likely to get an infection, and I think conjunctivitis in a dry population is missed a lot, so we culture these patients a lot. And serum tears in a large meta-analysis is of questionable efficacy, but in cases of severe dry eye, we use them. Absolute dry, Sika, graft versus host, Sjogren's, I think temporal tarsorrhaphes and tarsorrhaphes in general are a great tool. Amniotic membrane grafts in select patients. When very, very dry eyes come into the clinic, the best thing for these patients is to close their eyes. If this isn't working, if you have a dry eye patient that doesn't get better with tears and occlusion, then something else is going on. You've missed it. You have to go back and put on your detective hat and your doctor hat and figure out what it is. And it's usually an external disease process. So we talked about with anterior blepharitis, that's fine to use lid scrubs. We have a lot of Demodex in the United States. So we use tea tree oil. There's this topical ivermectin I think works well. Posterior blepharitis we treat like rosacea. There's usually an antibiotic steroid component topically, and we give long-term doxycycline, I think, much more readily than you give long-term doxycycline. With allergic conjunctivitis, yes, if it's mild, we all know we can do cool compresses, artificial tears, and a topical antihistamine. That's great. By the time anyone with severe allergic conjunctivitis comes to me, that doesn't work. Almost everyone needs a mild steroid. So the idea behind a severe allergic conjunctivitis is to quiet with the steroid and maintain with an antihistamine. I find antihistamines alone often don't get them as quiet as you need them to be. And it's not uncommon that we need to share our care with dermatology. We use a lot of tacrolimus on the skin for severe atopic disease. With EBMD, anterior basement membrane dystrophy, the diagnosis is the key. You've got to look for it. It's much trickier to find than you think it is. If you look carefully enough, I think you'll find it a lot more than you think it's there. We use bedtime lubrication, and then there's medical management of recurrent erosion, which is oral doxycycline and a low-dose fluorometholone for 3 to 4 months. That's German literature, and it's great for recurrent erosion. If they fail medical therapy, then we need to roughen up the basement membrane, so anterior stromal puncture, stromal roughening. Pearls for dry eyes. Avoid cumulative toxicity. We're all here to help patients. In fact, we make them worse a lot in a dry eye patient. Our drops can become really toxic. Remember, preservatives can be toxic, and remember that steroids can be, at least in the United States, compounded preservative-free, and I'm nearly certain you can do preservative-free steroids here. Is that true? Can you do preservative-free dexamethasone or something like that here? Is that hard? Not hard. Keep it in your mind because it's a savior for a lot of patients, is a preservative-free steroid. Fingers near your eyes is always a bad idea. There is really no role for high-potency steroid, difluprednate, for any of the diseases that we just discussed. People think if it's stronger, it'll work better. It really has no role for any external disease or dry eye. And then just remember that treatment response can be difficult to determine, and that it's our job to evaluate data objectively and carefully.